This is 90-minute live session composed of 2 live cases from Cedars-Sinai Medical Center, USA. Operator is Dr. Raj Makkar. And then we have 2 key lectures by Dr. K.K. Yeoh and Dr. Cheung Simon Lam.
Good morning, everyone. Thank you for being here. I think we have some very interesting live cases coming from the United States this morning. I'm David Cohen from Cardiovascular Research Foundation and St. Francis Hospital. My co-moderator is Professor Kim from here, right here in Seoul. And we have an excellent panel. And if we could just, before we get started, have everybody on the panel introduce themselves and say where they're from, starting down here to my right.
So thank you. I'm Takashi Matsumoto from Shonan Kamakura General Hospital.
Good morning. My name is Dr. Meemook from Ramanipidi Hospital in Bangkok, Thailand.
Good morning. I'm Simon Lam from Hong Kong, Queen Mary Hospital.
My name is Han Lee from Busan National University Hospital.
Hi, KK Yeoh from National Heart Center, Singapore.
I'm Joo-Yong from Samsung Medical Center, Seoul, Korea.
Good morning, Dr. Hosoba from Nagoya.
I'm Dr. Do-Yoon from Asa Medical Center, Korea.
Thank you all. Do we have Dr. Makkar from Cedars-Sinai available? Oh, look at that. Good morning. Hey, Raj. Hi, Akriti.
Good morning. Hi.
Hi, how are you?
Hi, David. How are you?
I'm great.
All right.
Looks like you're going to be busy, so we will turn it over to you, Raj.
Okay, lovely. So I heard that we have 90 minutes, and if that's correct, we will try to show you.
We have, somehow we have to fit in that 90 minutes also 2 lectures. So maybe there's a time you can say where is a good time for a break and we will have a 10-minute lecture. You just let us know.
Okay, all right, terrific. Okay, so this is what we'll do. So the first case that we're going to show you is going to be presented by Denizen. Let me, of course, to my right is Akriti, then Tarun, Denizen. We have Saba who's doing echo, Monica is doing anesthesia for us. We've got Marcella, we've got Ryan, we've got Loren. These are, the people in the room as well, and Tejas is prepping the valve. All right, and we've got a wonderful AV team. Let's go. Yeah.
Good afternoon from Los Angeles. Our patient is an 81-year-old woman with the previous TAVR, SAPIEN 3 to 23 millimeter in 2019. Now transferred from outside institution for the management of a heart failure due to bioprosthetic aortic stenosis. Pertinent medical history includes moderate to severe MR and reduction of ejection fraction from 65 to 30%.
Next one.
We're looking at the echo images. In the middle colored Doppler image, we see the floral acceleration and the mild aortic regurgitation. And then the current mean grain is 48 millimeter mercury. During the index TAVR procedure in 2019, annulus was measured to be 369. Therefore, 23 SAPIEN 3 valve was chosen, and it was deployed at -2, then nominal, as we see in this image. On discharge, the procedure we obtained a gradient of 13 millimeter. And again, she was enrolled in the result registry. On the CT imaging, we see no evidence of subclinical valve thrombosis. However, at 3 years, she started having elevated gradients and underwent repeat CT imaging, which revealed evidence of subclinical valve thrombosis. Because of this, she was started on anticoagulation with rivaroxaban without further improvement. At that time, mean gradient was 25. As we see the progression of the bioprosthetic AS on this chart, it went up from 13 to today to 48 millimeter mercury for the mean gradients. For this case, we considered both 20 and 23 millimeter TAVR intervention and planned our case with coronary and cerebral protection. Here we are looking at the both measurements for the 20 millimeter valve-in-valve. And then on imaging, there was no evidence of valve recoil, as we see in these slides. This is our patient has a type 2 arch morphology for the cerebral vasculature. And
Terrific. Thank you. So I think the key question here is how to really deal with this redo TAVR and what caused the first TAVR to fail. Is it the fact that we took a 23 valve, which was a relatively large for an annulus of 360, and we underexpanded it, that predisposed this patient to actually fail that particular valve? And then, of course, we saw calcification, and now we're also seeing severe aortic regurgitation, and that caused the valve to fail at 5 years rather than what it would normally be. Also, we didn't see subclinical leaflet thrombosis at 30 days, right? So obviously something happened between 30 days, and it could have happened at 6 months, 3 months, or any time point before the following CT was done, which was actually at 3 years because of increase in gradient. So I think we've agonized, about, because it's not very manly to put a 20 millimeter valve. You are actually undersizing. It doesn't look so good because you'd rather, put a bigger valve. The question is, would we end up with the same problem and then set up the valve for a failure? And of course, I think the important thing was looking at what is the situation of coronaries. So when you look at the position of the coronary, so this is just the Sentinel device. We just got it out of the way and we put it in without any trouble. It's a type 2 aortic arch. And then, if you look at the coronary angiogram there, we only wish that we were a little bit lower with the valve frame. Okay, so it's right there. And this is somewhat unexpanded valve. So I think that if we put a 23 and a 23, and which is what we have done in the past, when the coronaries are above, we would actually use a 22 high pressure balloon, like a true balloon, and then sort of go ahead and put a 23. So in this case, I think that we would still be set up for coronary occlusion, all right, which can be dealt with, but I think also then there's also the right coronary artery, which also comes off at, which is somewhat on the upper strut of the valve. All right, okay, so that's where it is. So that's the right coronary artery. Okay, so I think that it's uncharted territory. Obviously, the choice would be to put the bigger valve, but this is a combination of AS and AI. I just want to get some thoughts, from the panel. We also thought about balloon expandable versus self-expanding. I think coronary access does become an issue. You could use a balloon expandable 23 and actually do this. So, here is the case. I want to, have some discussion. And while you are discussing, we will try to cross the valve. Okay, so we basically have access and we have the Sentinel device.
Okay, you guys go cross, we'll discuss. So, Professor Kim, would you... What strategy would you use for this?
Before, I think this is really a representative case to tell us the weakness or limitation of SAPIEN valve, especially it is small. Just 1 month after deployment, mean gradient is 15. It's more than 10. Usually self-expanded valve with wide effective orifice area, less than 10. Second, probably they prescribe aspirin. I don't believe. If patient permits, I always prescribe dual antiplatelet agent to prevent thrombosis because SAPIEN has most high instance of valve thrombosis. Third, they prescribe levodoxaban when they found thrombosis. But I believe in prostatic status, warfarin is definitely better than NOAA. In my practice, I always prescribe warfarin to try to resolve the thrombus on the leaflet, valve frame.
So now we're still here. So we have to figure out how we're going to treat this, though.
I definitely use a self-expandable valve.
So you would favor a self-expanding valve?
Because when we implant 20 millimeter resilia, even though it is resilia, I don't believe the effective orifice area and their high instance of thrombosis.
I think certainly I think there are a lot of people who would try to use a self-expanding valve here. Do we have any other thoughts from the panel? Any other strategies or considerations that you want to discuss?
Raj, you want to try this one? It's not straight.
For me, I think it would be consideration for supraannular valve. The problem is bilateral borderline coronaries at the top of the frame. So if I really want to put in a self-expandable valve, I would do bilateral basilica for this purpose. And another way, if you really, because of the current concerns, put in a self-expandable valve, I would prefer a Trenti, which is maximally open it and protect on one side. The other side would be either basilica or unicorn. So this is our approach.
So let's go more specifically on those things. So you would protect
You want to stay
one side
anterior?
and do a leaflet modification on the other?
But I would go back to the CT first, because the problem with Sapien, you don't have commissural alignment in the first place.
Right.
So that will be crucial. If you do anything, this is the base fundamental, so I would check. But sometimes maybe good for one side and bad for the other side. And so a lot of things have to work before that. But coronary concern is definitely an issue here, and protection is the basic thing to do. Whether to do leaflet modification is the next step, whether based on the CT assessment.
Yeah, I think, Raj, are your commissures aligned or are they not aligned on the original implant?
We didn't think about, we thought that I think the commissures are probably aligned, as far as I recall.
Want to measure gradients, Raj?
Okay, let's just measure the gradient. So you saw that.
So it might have been
there are
possible
no
then
markers.
to do a leaflet modification
Yes.
if you wanted.
So I think, so this is, we've used the shortcut device and we've done basilicas. I think that, all of these have some risk, all right? This is an 82-year-old patient. Now, let's go back and answer some of your questions, because you had
gradients, please.
that you never use, I think the reason why you talked about that you always use dual antiplatelet therapy. There's no evidence that dual antiplatelet therapy actually is better than single antiplatelet therapy. In fact, a small trial called the ARCH trial just demonstrated otherwise, more bleeding with no benefit. In fact, in the RESOLVE registry, we had and the SAVORY registry, we had 1,000 CTs, and we looked at the impact, and we did CTs on everyone. Single antiplatelet, double antiplatelet, DOACs, and warfarin. And guess what? And there were patients who were on nothing. So single antiplatelet, double antiplatelet is as good, as bad as nothing. And DOAC and warfarin were exactly the same in terms of the incidence of subclinical leaflet thrombosis. So you can look at the gradient there. So I think
pretty high.
that there is no basis to actually say that. Now, the second thing is, once again, before the Galileo data came out, we were actually accumulating data on treating these patients with DOACs, and we were following them, and we saw the resolution of thrombus, which is why we started doing that. So despite the fact that the Galileo trial was what it was, with no benefit and possible harm, okay, in prophylactic treatment of patients after TAVR, we thought that we have enough evidence to sort of carefully use any of these drugs. And for practical purposes, most patients will actually be less compliant. So we end up using DOACs in these patients.
Do you sometimes switch from a DOAC to warfarin if it doesn't resolve on a DOAC?
Or the other way around, you know what I'm saying? So yes, we have done that, but I have to tell you that that is not the reason, we've tried one DOAC versus another DOAC and switching. I think it is more related to the timing of the initiation. When people don't resolve, I think it is more related to the timing. So when you miss treating patients early on, I think it is very hard to completely resolve the thrombus, okay? And we have case examples where we saw the thrombus, or we saw the subclinical leaflet thrombus, and this was in the days of the CT sub-study of PARTNER, where we saw that half of the patients actually resolved spontaneously. And so we told our patients, and some patients elected not to be treated. And I have to say, then a portion of these patients progress, and they actually are very resistant to treatment with anticoagulation. So I think that's just a little bit of background on some of the reasons.
It remains a very, very difficult area. You opened the Pandora's box 7, 8 years ago, and we still haven't got the definitive answers, do we?
Yes, but I think what I do believe, and I think what needs to be tested is that in patients who are young and not at high risk for bleeding, and such as this one, for example, this patient who's, despite the fact 81 years old, when we do a TAVR in TAVR, we will put this patient on anticoagulation.
Yeah, I was going to ask
So
that. I think that makes, I think for somebody who's already had a proven episode of thrombosis and you're just going to be having a smaller valve in, I think it makes good sense at that point.
So now we are going to put extra volume in this, because when we looked at the dimensions, they are around 300. So we are going to go ahead and put an extra 2 cc's in this. So our thought was that perhaps we can, keep this less complex, okay? And we'll measure the gradients, and maybe you're right that, we should have used a self-expanding, but we feel that there will be, there could be another chance if this patient lives more than, 7-8 years, there would be
There'll be
a
one
chance
more
to actually use that.
potentially. And you're going to try to just align the aortic sides, the top of the frames together?
So we will deploy this a little bit lower, because I think this is going to foreshorten, when we put extra volume. So I think if we can spare the upper strut, we minimize the chances of occluding the coronary artery. Okay?
Can we test pacemaker one more?
So I think this is, doing this procedure is not very hard, except occasionally the valve can be, but I think it's all about the planning, and I think you can make it as simple, but you can also go ahead and actually modify the leaflets and.
Yeah, I think, I mean, the beauty of TAVR has always been that it's a very simple procedure, especially now. And so we do risk making it, much more complicated than we need to sometimes, and that's the challenge. That's the art, is figuring out how to make it as simple as it can be, but not too simple, whatever that is.
Yeah. All right, terrific.
So
we've had strokes after basilica, you know what I'm saying? So I think
basilica is not completely benign. No, it's we get spoiled. We have, we have Jaffer. We do, anything we can burn, we seem to burn. But I think I don't know if we need to.
All right, terrific. Okay, ready? Pacer ready, please. Pacer on. Okay, let's go up, please. Okay, go. Off, please. Okay, I forgot to mention Wen Cheng. So Wen is our cardiothoracic surgeon. So as you saw, he inflated that with a lot of vigor. All right. Saba, I see good flow in the left main.
Yeah, so that's the first thing I wanted to look at, just to make sure. But as you see, there's flow in the left main, so that's patent. The valve looks expanded as like the 23, so I think it expanded within it nicely. Let's take a look at the color. So obviously, let's go off the coronary flow, color. I'm seeing some trivial leaks, and they seem to be coming maybe between the two stent frames. So let me take a look at that.
So do we have a 21 true in case we need to use it?
Yeah.
Okay, but let's.
Like you see how they're coming between the two stent frames.
Just tiny. That's
tiny touch, yeah, like they're trivial.
Barely, yeah.
And some very trivial valvular. So
do you use TE routinely for these valve and valves, Raj, or just in this case to see the left main very quickly? What was?
I think we are learning. We want to gather information. So I think so that's the reason why we sort of used.
It's always
TE.
nice to have the most. Yeah, you get the most information. That's for sure.
Yeah.
And if something goes crazy, you can get additional information very quickly. So it's a nice to have for sure. For all that, so you're going to measure the gradient now and see if you need to further expand this?
Yes. Let's see.
You have a target in mind where you will feel compelled to do something? 10? More?
I think.
No, it's over 10. It's over 10.
In this tubing.
So this is. Did we get rid of the contrast? So this is real.
Yeah.
Yeah, okay. So I would say then, I think, so what is the dimension of the,
It was 19 to begin with.
yeah,
The prior valve, the
Can you
the
measure
TAVR
it?
was 19
yeah.
millimeter.
So have we expanded this valve to 21?
I get a gradient, gradient of 21. I don't know how it compares to yours.
Severe stenosis turns
Well, I
to
have-
mild stenosis. Yeah, still stenosis.
Frustrating, yeah.
You know, if you look
Yeah,
on
well,
fluoro,
hopefully
we see
they
some
can-
dead space between the two frames.
Huh?
On fluoro, we see some dead space between the two frames. I think even
I
if you
think,
just
yes. I think what
switch-
we need to do is we can take a true 21 true, please.
Especially that I'm seeing like PV leak coming through them. That's also like
Yeah.
That's
a
pretty
sign of
rare, yeah.
some room.
Yes, so let's take a 21 true balloon.
Yeah, it makes sense. Try to really push it. I mean, we are definitely entering this, this era of increasing, valve and valve, either TAV and TAV, or, mostly TAV and TAV increasingly. What proportion of your procedures now, Raj, would you say are repeats?
We want 5 cc's in there.
I think they're still low, right? But I think it's reasonable to say that we end up doing a couple of
5 cc.
redo TAVRs every month. Occasionally, there was a month when we did 4.
Okay.
One a week.
Well, considering
I
you guys
think
do,
that,
50 or 60 a month.
Yeah, we do about 7.
70 a month?
Yeah.
Okay.
Before post-ballooning, I think we should do angiography around the left main.
They've got the
Yes.
guide there. They can do that.
So we, as you see, we do have a guide there, yeah?
Deflator, please.
Yeah, so, I think we're all learning, and I think, the question is, yes, we can, if this was a young patient, for sure, I think we would have been a lot more aggressive, yeah?
Can you pull the echo coming up.
Is that wire okay? Fluoroscopically, it looks like way out there. Yeah, can you just go in a different view, please? All right,
It's a
can
bit
you make a
proximal,
box
but
out of
you
that frame,
could
please?
fix it. It's
All right,
quite
okay.
proximal.
So,
Okay.
all right. Ready?
Put the probe back.
Okay, so Wen is going to take this up. Okay, ready, pacer on, please. Okay, let's go up, please. Okay. Okay, down, please. Off, please. Did we take it up?
How high did you
all the
go?
way?
14, 16?
16.
Okay.
Can you look at the flow,
Yeah,
please?
I'm
in the
looking
left
at
main?
that. That's the first thing I'm going to look for.
Can you walk this up, please?
Yeah, there's still good patency in that left.
Well, we had a lot of discussion, and I have to say, Tarun was very much opposed to using a 20. So
Yeah. Well, Haroon's
we had a lot of discussion. We went back and forth, and we actually had both delivery systems open. You know what I'm saying? So,
It's a tough-
Fluoroscopically, it looks much bigger now.
but I hope we have not created central. I don't see any
I
central.
don't see
yeah?
central.
Okay, so I think, let's see.
The gradient looks better by echo.
Yeah, I think it would be good.
And did you
So what is the gradient by echo?
I'm measuring it right now. I just took the pictures. So we started off with the 24, and I'm now down to 4.
4.
Oh, that's a
Okay,
big
4
difference.
millimeters. Okay.
You going to recheck the hemos? Yeah, great. So did you
Yeah,
have a,
I would check.
do you have a stent in that LAD or just a balloon there, Raj?
Just a balloon because it's in the upper part, so.
So you felt you could be able to deliver something antigrade if you needed to after ballooning?
Yes.
Okay.
Yes. I mean, how much do you complicate, right?
No, I hate that, when
occasionally-
trying to get a stent out.
And occasionally, yes.
Yeah, so 4 to 6 for gradient. I'm not really getting anything more.
Oh, that's
All right.
better.
Is the contrast out? All right. So we're getting the contrast out of the catheter and
Much better.
have a visual.
It looks like it's in the high single digits on the hemos or something now.
Okay, but normally we criticize the echo gradients. This time we will take the
praise
echo
them?
gradients.
Yeah.
Good, 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 good.
All right. So
We didn't, do we see the LV? Or are you just zeroing?
where is the LV?
You have nothing now. LV.
Akriti is
There we
doing
go.
some magic to bring the
Ah,
LV
Akriti, good
pressure
job.
down.
You made it get better.
All right, so I think it is better. It is not perfect, and there are pros and there are cons. I think that we can, we will start this patient on anticoagulation and hope that this valve will last.
Yeah, I think that's the best. I mean, we know that from the trials, not that they had valve in valve, but the trials with DOACs had, very, very low rates of thrombosis, right? That's the one thing we know is when they were started on it prophylactically, there were, bleeding issues, there were mortality issues, but thrombosis was not an issue. So I think you can be fairly confident that you will prevent thrombosis with a DOAC. Will you give any antiplatelet or just a DOAC?
So what was the mean?
9.
9. Okay. All right. Okay. So I think, so that's what it is. I think we'll go ahead and remove.
The other thing is the gradient invasive may be higher because there's stuff in this guide.
Oh yeah. Actually, why don't we do that? Because we have material in. Okay.
Balloon.
Yeah, actually.
Yeah. So I think that.
Let's flush it now.
So let's flush it because we had the wire, the balloon. Good point, Arun.
Are you going to do a coronary angiogram as well at the end?
Sure. I think we can.
Let's measure gradient now.
Okay, so that is the gradient now. That's your real gradient.
We don't, oh, here we have it. Ah, even better.
Can you?
Much better. Good point.
All right.
Hassan. Yep. 2.
Okay, so can you
snap it?
oh, snap it, please? Okay, so I think that our valve landed lower. We can, of course, go ahead. You guys take a picture to show that, everything is okay there, which should be, because we have good flow. We have good flow in the left main.
Mm-hmm.
Yeah?
Yeah.
Just put a picture and take a non-slide.
Yeah,
Okay.
recommend you disengage it.
Okay.
Yeah, flow looked good on echo. I didn't have any concerns.
Okay, the flow is good on echo? You have no concerns?
Yeah.
Okay. But I think it's a good idea for our learning.
Yeah, I think if we can get the
picture
good view with it orthogonal and just.
Yeah. Test, please.
It doesn't even have to be selective, just non-selective would be fine.
I'm trying to make a box.
LAO was your box.
Yeah, that's true.
Okay.
There you go.
Okay, so okay, so
No
it's-
change, yeah.
it looks good. Okay, so this is what we'll do. Dave will go to the other room where Mamu is waiting.
Okay.
And what we will do is we will show you another case, which is, can you hear me?
We do. We've been hearing you. Yep.
Okay. So what we will do is we'll show you a case of TAVR in aortic regurgitation. And then, we have, and then you can do your talks, but we have, we have a 23-minute or 24-minute recording of a tricuspid valve replacement that we did 2 days ago, specifically for Asia-Pacific valves, because Moody, our imaging person, actually, had to go to Egypt. So, so we can fit all of this, because this is not going to take much time because Mamu has already done most of the procedure. But let's go ahead and present the case, please. Sure.
So this is your aortic regurgitation case.
Yes.
That's
okay, great.
So the Raj is just coming into the room. So Syed is one of the advanced interventional cardiology fellow. I'm a Mamo Nakamura. While he's scrubbing, let me introduce everybody. Thank you for coming in. Thank you for allowing us to have this opportunity. We have the Paul in the tech, Surakuv in tech, and the BD is the nurse, Minor from the Edwards supporting cast, and actually Sahara and now the Cynthia is doing the monitoring. Anesthesia is Dr. Tao Shen, and the Saber is coming for the TEER again. So this is our case, and the Sayedo, please go ahead and present our case.
Sure. So, good evening, everyone. This is a 66-year-old female with multiple recent hospitalization for decompensated heart failure, which was attributed to severe aortic regurgitation. She actually presented to clinic with symptoms consistent with New York Heart Association Class 4 symptoms. Her past medical history is significant for CAD and PCIs in 2011. More interestingly, she actually underwent a type A aortic dissection repair in 2018 in Sweden. And she's got a history of heart failure with preserved ejection fraction, hypertension, and CKD. She was recently admitted to the hospital and was found to have renal failure, underwent a biopsy which was consistent with proliferative glomerulonephritis. Next slide, please. So here on the images, transthoracic images, you can see that the LV function is not terribly bad. It's on the lower end of 50 to 55%. And the image right, you can see that there is severe significant AR, wide central jet. And, looking at her CT, we see that there's a large annular size of 410. The sinus of the Valsalva, the sinuses are large at 33 average, and her STJ heights are also pretty high at 26. So we noted that she actually has what's making this case slightly challenging, she has this kink in the ascending aorta, and we can appreciate that there's a pseudoaneurysm. Her left coronary height is slightly low, at 8, and the RCA heights are fine. And for our approach today, we went through the right, common femoral. And next slide, please. And so she's here for severe symptomatic aortic regurgitation, and our plan is to, utilize a 26 millimeter Sapien 3 valve today.
Okay, so once again, this is not an easy case, and there's a lot. She's very frail. She's spent months in hospital, so the surgeons were not really enthusiastic, and for her to have another sternotomy would be very, very hard. So that's the reason we've chosen. Now, we talked about JenaValve, but because of the kink, which is, whenever you have a problem which can affect the sheath and the locators, the way it will come down, they're not excited about doing the JenaValve as well. So I think otherwise, our first option normally is to use JenaValve in such cases.
Yeah, I was going to ask about that. Because I know you have experience with it. So that's a good thought, though, that it's not a very flexible device. It's quite stiff. So I think that's reasonable. I hear, and I'm sorry, the annual size was 400. Did I hear that right?
Yes, the annular size is about 440.
410 by the CAD.
440. So we are hoping that, and I think it was the same by TEE. Yeah.
Yes.
So you have a substantially oversized Resilia here.
Yes. So I think, we were discussing. So we are of course going to. Ben is going to feel it. He's also going to look at the pressure gauge. Okay, we don't want to exceed 6 atmospheres.
We haven't seen the rotorotherapy to assess the aortic regurgitation severity.
Yes, can you, Saba? Saba, can you?
It looked quite severe.
I'll show you some slides from pre-procedure. So this is what her AI looks like. It is a tri-leaflet valve. Without the color, you could really appreciate there's some very mild areas of thickening, but otherwise the valve is malcoapting in the center. There are pliable leaflets. This is again what the AI looked like on long axis and short axis. You can see how the jet goes all the way to the commissural. If you look at it from the transgastric views, you could appreciate how widely open this AI is. I mean, it looks like a waterfall. Yeah. When we look at the gradient, it's not very significant, but you could see the AI jet. And again, we are not really well aligned to get a full, a Doppler angle that is optimal to measure this pressure half time. But even with a suboptimal alignment, we get a pressure half time in the 400s. her EF, even though the function looked pretty preserved on echo, you could see that it's not exactly normal. So with this degree of AI, that's abnormal. It should be hyperdynamic.
No, that's
So
a
this
good.
is pretty much what I saw on baseline.
I don't think there's much question that she has severe symptomatic aortic regurgitation. That's not, that doesn't seem to be in question here.
Yeah, I mean,
good-
off-label use of these devices is not without risk. We know that the risk of valve embolization, is much higher. I think we've all had some learnings. We've had embolized valves, and there are times we try to compensate and actually oversize. And we actually, I think about 3 years ago, we actually even had a case of aortic root injury. So I think this is nothing to be taken lightly and to be done in a cavalier fashion, yeah? But I think, so here we do have a patient, and this is actually, we were not planning to show this patient. This is a patient that came essentially yesterday, in bad shape.
Did you have baseline hemodynamics? Is there anything interesting to see on the aortic pressure tracing?
Yes, can you show us the baseline hemodynamics, Mamu?
Sure. Can you go back?
Well, I've not heard diastolic pressure is like in the 40s.
Right.
Yeah, it's not as.
Basically,
This is very. It has to be chronic, or she'd be quite sick. So.
Can you just play back in the baseline hemodynamics? I think the typical AI, the diastolic pressure is low, EDP is high.
Yeah.
A little bit of gradient systolic.
Can you show the cath gradients, please? Can you bring them up?
If you can't, don't worry. We've seen them before, but I thought it could be instructive.
Yes, that's true. We got all the information here. This is a coronary.
There we go.
So diastolic pressure 39 in the aorta.
Yeah.
But there is a diastolic gradient, so it's not acute. It's very chronic.
Yeah.
Which is
Very classic,
great.
yeah.
All right, we'll see how that changes.
Okay, so let's see and let's hope that we'll be okay.
This is a coplanar view, deployment angle from the CT.
All right, so unlike aortic stenosis, with aortic regurgitation, we like to be a little bit low because the anchoring will occur not just in the annulus, but also in the LVOT. Yeah, the LVOT was a little bit larger. So, test please, yeah. What do you think, Ben? Do you feel okay here? Huh? Yes, I do. All right. Okay, so this is what we will do. We will do a pacing at 180, then we will go up to 200. Okay? When you take a feel, how much were you planning to give?
I think it's going to be close to nominal, which would be
All right. Okay. All right, terrific. Okay, pacemaker ready. Pacemaker on, please. We are not capturing, guys. Okay, now we are. Let's go to 200, please. 200? Okay, inject, please. Okay. All right. Okay. Okay. Down. Off, please.
So that's more like a 60-40 deployment, yeah.
Yes, because, just as I mentioned, I don't want to come back too much because there is this kink, and I think we got lucky that we didn't really, get hung up on the kink. So let's see. I think we need to be. Do you see any VC central leak?
We see central leak.
Okay, I guess I have no choice but to come out
I think
back so that.
Yeah, I'm seeing some very trivial PV leak right now.
Okay. All right.
Yeah, and some trivial valvular leak.
Okay. Let's also fluoroscopically take a look at this valve. So when did you empty it?
You may want to dilate again.
I left 2.
2, okay.
Yeah.
So, but we took +2. So
Raj,
did you give nominal or you did it?
Nominal.
Nominal.
How
Okay.
much is the oversizing index?
I think we are about 20%.
20%?
20%, 22%, yeah.
so this could be wire related, and
Yeah,
it
this
could
is
be
wire
causing
related, yeah.
overbleed and maybe make it look like paravalvular.
Okay.
So when you remove or change your wire, I could take a look at that area.
Yeah. Also, we'd like to look at the frame. You know, if you look at the frame of the valve, you see that the lower part is moving out a little bit.
Yeah.
That reassures me that we have good anchoring.
You're certainly subannular there. Yeah.
Yeah.
It
And I think it looks pretty
looks solid.
dug into
It
the
looks pretty good.
septum.
Yep.
Yeah. Okay, so all right, I think we can come out. And let's do the gradients, the hemodynamics, so that we can show the pre and the post.
Yeah, it looks like a, you know,
And
good result.
when not necessary, we don't like to post-dilate, because post-dilatation, and that's happened to us, post-dilatation, you know, an embolization of valve is real, and that's actually even published in the multi-center registry. But we do want to make sure that it is properly anchored, because over the last 15 years, we've had a case where the valve embolized into the ventricle, you know.
That's no fun. Yeah, that's not.
Yeah.
You need to push it really hard a little bit right, because of the kink.
Okay.
Keep the wire there,
The
and I think we
fluoroscopy,
need
there
to
is no
just
calcification around
No,
it complex.
It's a
No, none.
young,
No calcification.
young patient
Okay.
with aortopathy. Yeah.
Okay. So
All
I
right,
think,
so this is the view.
yeah, we put a multi-purpose catheter, so now that's causing a little bit of
Yeah,
central.
same place the AI. I think it's coming from your wire. If
It's
there's
a
a
multi-purpose catheter.
if there's a PV leak hiding behind it,
There
it
is
would
a-
be hard. I mean, it would be hard to see it, but I'm not really seeing anything significant other than that.
There is even
wire
though it's
leak.
unforeseen, there's a kink over there on the
Yeah.
top part of the ascending aorta.
Mhm.
So that may impact on the way like this catheter goes. See, like there's a little bit bend. I think Raj is okay. Let me just do the hemodynamics. Okay.
I think it's like, I mean, it's going to be a heck of a lot better than it was, right? I mean, you have a,
Right.
and I doubt that central AI is going to persist once you remove the catheter.
Yeah.
There's a little bit gradient, but I'm just wondering that kink in the ascending aorta may cause a slight.
Okay.
So this pigtail is already out from the beyond this side, so.
Yeah.
it
Okay,
just
I
makes
think there is not much of a gradient, right?
We don't see the hemos yet.
Saba?
Not that I saw, no.
Oh,
Okay, all right. So I think we just wanted to demonstrate. I think it's time for us to take a break from you, and I'm hoping that you will have time so that we can show you a case that we specifically recorded for you.
Okay.
If not,
We
understand.
will come back to you in about 20, 25 minutes or so, Raj. Is that good?
Okay, yeah, that's
And
fine.
we'll do our 2 lectures now. Thank you so much. The great cases, and thank you for. Okay, so we have 2 talks coming up on the tricuspid valve. The first one is by Professor Yao, and it is tricuspid TEER, facing limitations, inspiring progress.
Hi, good morning, everyone. Thank you, chairs. I was given this talk, and I was thinking to myself, what a title to give, Facing Limitations, Inspiring Progress. I'll try my best to give a bit of context to the content of the talk. These are my conflicts of interest. So we know that TR, which is very different from the aortic regurgitation and the aortic stenosis we saw earlier on, is a much different animal, and we have limited treatment options. Medications for symptom relief, surgery in general has been associated with high mortality and morbidity, and therefore it is an unmet clinical needs. What are the challenges? First, we know that the tricuspid valve has a variable morphology, and Rebecca Hahn and others have shown that the variety there includes multiple leaflets, and that makes a specific treatment sometimes complicated. The leaflets are fragile and can be thin, and the chordae can be torn as well, a little bit more so than the mitral, in my opinion. And then there is the problem of right ventricular dilatation and annular dilatation, which makes also some of our therapies limited, especially for TEER. And on the right side, you see some of the imaging challenges. I remember the first time I saw, I think, Becky do a trial line, was it London Valves? People stood up to clap because the imaging was just so spectacular for what is a very difficult to image area. And on this slide here, you see that there's pacemaker wires, there's shadowing, and there is a movement of the heart, which makes the leaflets disappear and appear, and essentially makes the proceduralists and the echocardiologists have nightmares. There are various therapies available in the transcatheter space. Most of them are investigational. Some of them have gone away already. But right now we have the valve replacement, which Simon will talk about shortly. And this topic today is on TEER. And for the purpose of illustrating some of our learnings, I'm just going to talk about the TriClip, which I think we are, for those of us who have it in our respective countries, we have access to. The current generation is the G4 platform, which has the standard 4 clip sizes. And the main difference is actually in the clip delivery system as well as the guide. I won't spend too much time here except to say that this has been a game changer for the tricuspid valve. When we used the mitral clip for treating TEER, it was a lot more complicated and so many steps that mere interventional cardiologists usually cannot remember. So this paper came out, and this is on a triluminate study. Just a few key points. It's the first randomized controlled trial for transcatheter tricuspid valve therapy. The patients were symptomatic severe TR patients with intermediate or greater or higher risk for tricuspid valve surgery. 350 patients over US, Canada, and Europe with randomization 1-to-1 and both the first gen TriClip and the subsequent G4. Now, I think I won't go through all the baseline characteristics. I just want to highlight a few key points. First, on the left side, I forgot to put a red arrow there. If you look in a sort of lower down, the rates of pacemaker devices or CIEDs was about the 13 to 16%. And on the right side, where the red arrows are, just the measure of the severity of the tricuspid regurgitation, largely in the massive and torrential range if you use the 5 category classification. The coaptation gap is about 5, a mean of 5 millimeters, 5.5 thereabouts, which is important in our practice to take note of. So the primary endpoint is a complicated one. They are listed here in at the bottom right, there for tricuspid valve surgery, heart failure hospitalization, and KCCU change of more than 15 points in a hierarchical fashion. And TriClip therapy won primarily on the basis of the KCCQ change. What is also important to note is that for mortality of tricuspid valve surgery, this was about 10% in both arms. And I want to highlight that obviously there was improvement in TR, and you can see that the majority of them went to moderate and even some mild at 30 days and subsequently beyond that to 1 year. So this therapy clearly works for some people, but I think the surprise for those of us who are in this area is why was there no hospitalization or mortality benefit? And again, this you can see that the residual grade of TR, there was a significant improvement, and there was a change for more than 2 grades in a substantial number of patients. The device is safe. The only thing that caught my eye and which continued to be frankly quite a pain for those of us when we release and deploy the device is SLDA, and this is stuck at 7% in this trial where expert centers are performing with a gap of a mean of 5 to 5.5. So this remains a problem. Now, what about complex anatomies? I just want to highlight that there are those patients who were not randomized on the basis of the fact that the results were expected to be less than 1 grade reduction, more than 1 grade reduction, but not to moderate or less. So these form another cohort of single-arm patients, and I just thought to highlight that you will recall that these patients had, in the previous cohort, had about 13 to 15% CIEDs. This one had about 35%, and there were more patients with prior aortic and mitral intervention, presumably messing with the imaging. The TR severity were also worse with more patients with torrential TR, and the gap was greater at a mean of 7.4 compared to 5.3 in the randomized patients. And I think this is important, and not surprisingly, the tricuspid valve annulus was also greater. In terms of procedural outcomes, technical success was achieved in both groups. And I think this highlights that in expert hands, you can have a good result despite some of the challenges which are highlighted: big gap, a large annulus, and a torrential TR. The adverse events remain low, and unfortunately, as I mentioned, the pain that we all experience is when there's SLDA, and this remains at 7.5%. The next few slides I'll skim through very quickly because, not surprisingly, there was a sustained TR reduction, KCCQ improvement, and what is important, however, is to note that all-cause mortality remained significant at 15%. The randomized patients were at 8.6%, and perhaps the TR severity was a marker of poor comorbids. It's hard to know in this setting. So now let's change a little bit from the triluminate to the BRIGHT study, which this is an older slide set from 2022 when Philip Luz presented this. And just quickly to say that this was a single-arm, multi-center registry. And importantly, this was a real-world experience, and they had a central core lab to adjudicate echocardiographic findings, as well as, I think, a central adverse event committee. The earlier presentation showed a good implant success, and the most recent results were just published this week in JACC. And I happened to be looking at it and managed to put these slides together. So the results were excellent. The safety profile was great. You can see the SLDA has gone from, in a triluminate study to less than 4% at 1 year in the BRIGHT cohort. The coaptation gap, I should also highlight, in the left side of this table is about 6.5 millimeters, and the majority of patients were massive as opposed to torrential. So this was what we had, and one other point which I thought to highlight is that the cardiovascular mortality, which you had seen in a triluminate study, that was all cause. In this case, the cardiovascular mortality was also 8.8, but it's cardiovascular, and all-cause mortality was 15, similar to the single-arm component of the triluminate study. Not surprisingly, the patients did well in this cohort, with patients having TR reduction largely to moderate or less, and had similar KCCQ quality of life improvement. So these studies were reassuring in that in the real world, patients get benefits with TR reduction. Now, the study also showed that predictors of 1-year mortality were the following: worse residual TR, if you have more than moderate TR, is bad, worse renal function, and worse TAPSE. The question is, what does it mean? And I'll come to that in a while. Separately, the Pascal technology is also undergoing its own TR trial. Won't go to that. Don't have data on that to present here at this point in time. Just a few other thoughts. There are some technical predictors of success in the literature. If you clip the anterior septal leaflets, more likely to succeed. The gap is less than 7, more likely to succeed. If you have adequate leaflet length, especially the septal leaflet, greater chance of success. And if you don't have to deal with CIEDs. And there are algorithms that help you plan your strategy. So this part is where I mulled over a little bit and would be happy to hear the panel's thoughts. The first is the mortality. Why is there no mortality benefit despite remarkable TR reduction? Is the mortality good or bad? Is 8% all-cause mortality bad, or are we expecting more? So how do we make sense of this? What was the patient selection like in BRIGHT? Is this sufficiently real world? Can we expect this in other territories? The triluminate study, obviously being a randomized controlled trial, had a lot more rigor. What should we expect in real life? And I had mentioned the fact that moderate TR, worse than moderate TR at the end of a case is associated with worse outcomes. Is it the chicken or the egg? In other words, can we be sure that the residual TR is the problem, or is it because the preceding risk factors that are associated with worse outcomes drove the mortality in the BRIGHT study? SLDA remains a concern. If you look at the BRIGHT study, it's 4% at 1 year. At triluminate, it was more than 7 to 7.5%. So it remains a concern. How do we make use of the right heart cath to help select patients? What is the role of the aggressive medical therapy in BRIGHT? How long should we wait before we treat a patient? If we wait too long, the gap gets bigger. Should we treat earlier? The timing remains an issue. And then, of course, we haven't seen some of the newer technologies which we have known of, Dragonfly, Gemini 1, etc., and how they will also change the landscape for TEER therapy for tricuspid. So as I mull over these thoughts, I can't help but think that, yes, it is. We do have limitations. All these challenges remain, what I've just listed before. But there is tremendous progress. 10 years ago, we wouldn't have imagined these results today. So this is inspiring progress. So I would say that the improved technology with the G4 platform and the better experience has resulted in a better TR reduction and improved clinical outcomes. There are gaps in our understanding still, and the physiological and anatomical interplay remains something we have yet to study. But in the meantime, I think this is clearly a very forward-looking. There's great progress, and we are delighted to be part of this arena. Thank you very much.
Thank you. I hope we'll have a chance to have a little discussion at the very end. Professor Kim?
Okay. Next speaker is Dr. Cheung Simon Lam from Queen Mary Hospital, Hong Kong. Title is Transcatheter TV Repair versus Replacement. Who will be the winner? Dr. Lam, please.
Thank you so much for the introduction. And this is difficult to say who is the winner, but let's share some of the experience that is as a center. We're doing both cases with patient selection algorithms. And sometimes it's difficult to say who is the overall winner, but individually for a particular patient, one may be a more preferred option. So just to share some cases before, and this is a TEER. We can use the TriClip and also the Pascal and Dragonfly. And you can see that nowadays the procedure is streamlined, and like in this case, at a concomitant mitral and tricuspid. And the tricuspid annulus is dilated to some extent. We think we should do things in a concomitant, in the same procedure. So quickly we finish off the mitral, and leaving behind we can see that there's a big wide gap with a big regurgitation. So we decide to treat the patient in one go. So after putting in 2 mitral clips, then we put in the second and third TriClips. You can see that we are adopting the ICE protocol for the 3D ICE to guide the procedure, and it improved the safety because we don't need to go out with a TEER probe sometimes, so it result in GI bleeding. And for lips left grasping, it's ultra clear for individual grabs. So this is streamlining the procedure, and the procedure can be can be complete even with this concomitant procedure within 1.5 hours. And the second scenario is a patient with a pacemaker lead. Nowadays, we gain more experience. First, we have to evaluate whether the lead is affecting or is a bystander. And most of the time, in this scenario, it is pushing against the septal leaflet with splinting. So there are different strategies to help this patient. And in this case, we decide to put in clips and to septal commissure. So you can see this ICD lead. We are orientating both from X-ray and also from TEE. And this is more clear from a transgastric view, just a visual orientation. So this is the septal and anterior posterior, and you can see these moving dots is the pacing lead. And this is where the first clip is clipping. So we are trying to do some endoroplasty effect so that we can isolate the lead. And the lead is still mobile. So this is the first clip resulting in some reduction in TR. And we carry on with the second clip, and you can see this image. We just carefully locate our clips and orientate it so that it aligns next to the second one. And this is the final results. And you can see that although there's still some residual TR, but I think it's unavoidable because the lead is still moving around the area, but significantly improve the patient in terms of symptoms. So next will be an option in our locality is heterotropic bicaval stenting. In some patients, definitely is not eligible anatomically for TEER. Like this case, with also concomitant mitral ring failure with severe combined stenosis and regurgitation. And on the first stage, we do the procedure on the Waffen ring with a sapien. Then because it's not, after screening, it's not eligible for replacement or TEER, so we proceed with the bicaval stenting. It's an option, it's not the best option, but it helps the patient in terms of symptoms. We're using a CT to guide the landing zones, whether it suits the dimension criteria for the IVC and SVC stents. And the procedure is actually very simple. It's nothing compared with the valve procedures. It's kind of stenting, and we have landmarks on the X-ray to guide the procedure. And this is one option for our patient. Like in this one, we have left side disease treated invasively with catheter means, and then on the right side, we also put in this bicaval valves, and this patient is doing fine so far. So we have options of orthotopic TTVR, which is the key for this lecture, and there are several options. But the problem is really depends on your locality, the accessibility of the device, and the approval process at your locality. And like in this case, we can see this is not the kind of case you may try to attempt TEER. We did that before, but sometimes we can try to minimize the regurgitation from torrential to severe, and that comes back. We can do some commercial bridging, tissue bridge to help reduce TEER, but you can see the gap is so wide, it's very difficult to perform TEER. Instead of a half-hearted TEER, then we decide for the replacement. And what we have in Hong Kong, for example, is either a cardio valve or a lux valve. And in this case, we use a lux valve, which is a transstructural approach. And so you can see it is also TE guided. And nowadays, with the experience gaining from TEER, we can use the same way to do MPR sweeping with the X-plane and to guide orientation, trajectory, to optimize the implantation. So this is a handle that uses several lobes, helps you rotate and orientate. And this is the rabbit ear that hugs believe the posterior and two leaflets as an anchor. And you tuck until you have a feedback, and you have the septal anchor that help to, so this is the 3D, this is ice. So we also use ice for this purpose, the vericyclo, and you can guide your procedure like in the same way as you're doing a tri-clip. So we carefully locate the two rabbit ears. One is in the posterior and one is in the anterior before we deploy the rest of the device. And this is the real-time ice image showing the expansion of the valve platform. And to avoid this overrun, so this is the next step is there's a septal anchor. So after the leaflets are hooked from below and the septum, there's a fixing mechanism so that it will stay very stably at the septum. And this is how we look at this is TE. You can see that the LV, this is the septal tongue, and there will be an anchoring process. You can see it's now like anchor on the septum. And the result is usually very good and eliminate predominantly all the TEER. So this is the last case. We'd like to show that this is what we mean by half-hearted TEER. So we try our best to improve the patient's symptoms by putting as much as clips, and the patient originally have a very wide gap and without other options, and it recurs after like 2 to 3 years. So they're leaving behind, the options are limited because if you have something there, you have to be very careful. Maybe it preclude you from doing something else. You do bicaval stenting is an option, but in this case, luckily it is in an anteroseptal commissure. It won't affect the anchoring mechanism of the lux valve. So we do CT assessment and do the same thing carefully, and you can see there are many clips. 2 belongs to the mitral side and 3 on the tricuspid side. And the patient had a very good results. And there's some leak because there may be still some interaction at the pre-existing clips, but it's still acceptable, and the patient's doing well afterwards. But definitely had a long stay in the hospital for rehabilitation, medication titration, which is usually the scenario for patients with tricuspid regurgitation associated with different degree of RV impairment. So for comparison, so we know the data, KK has shown us the triluminate data. improve the symptoms and quality of life, improve the TR, but we need more data to show it in decreased mortality. And the problem is at 2 years, it still remain good, but still coming back with severe TR at most is like at least 30%. And Transcatheter is learning from this experience, this is the way to eliminate nearly all the TR. And this single-arm study is showing very fine results with improved NYHA class and decreased TR severity. And this all set the background. So this is to put the table for comparison. So the Transcend 2 trial is to a randomized trial between optimized medical therapy and EVOKE plus OMT. So from surgical experience, definitely repair wins because isolated surgery or it's a multiple valvular surgery involves tricuspid replacement. It shows comparing replacement, it has lower mortality, lower rates of permanent pacemaker implantation, less hospitalization, renal failure. And the problem with sudden elimination of all the TR may result in early negative physiologic impact of the overall RV because of the poor RV function. And there's a rigid prosthesis over there, and it will actually improve the basal function of the RV, and there will be acute RV afterload mismatch. So in some of our cases, very successful procedure results with elimination TR, but patients still have a clinical course that is quite stormy, and we need to stabilize it. Eventually, they can get out of the right heart failure, but it needs some time. And then the dysfunction will lead to adverse long-term clinical outcomes. So we know anatomical criteria, if you just look at two images, patient A, patient B, presume all has been adequately dehydrated in an optimal position. So the left side you may consider TEER as a primary approach, the right side with big gap as a replacement approach. So we know the traffic lights is similar to MitraClip or TriClip. So there are criteria, especially on anatomical criteria, showing which one is more favorable in individual patients. The strains or TEER, definitely you have more experience, a variety of TV etiologies you can be able to manage. There's low risk of thrombosis, and if you have a lead, that's okay because you don't trap it. There's less chance of dysfunction of the leads. Conduction abnormalities will be less chance. And theoretically, there are low risk of acute RV afterload. As a bonus, if you could not eliminate all the TR. But the weakness, you have single leaflet detachment as told by a KK, and residual TR and procedural imaging will be very demanding. TTVR usually is independent of the different types of TV etiologies, and no issues of single leaflet detachment, but you still have risk of migration if you don't have the valve properly implanted. You have issues of device thrombosis. You need long-term anticoagulation, pacemaker replacement, more access issues, bleeding, and adverse events, slightly more procedural events with a TTVR. And the local approval is the key. Actually, you know there's a very good device, but it's not available. There's nothing to mention about. So there are different levels of approvals, and most importantly is the local approval. For example, Hong Kong, Japan, Korea. It depends on what tools and gadgets that are available in the cath lab. So other potential factors, which I think is more important, as I said, device accessibility, the training and technical access, imaging support, definitely, because TV interventions, definitely imaging is the number one thing we consider. Patient screening logistics, you have very good therapy, even replacement wins, but only 2 out of 10 patients you can treat. That's nothing. I will still consider a TEER because more patients can be benefit. And case volume, because you need a case volume to build up your expertise. Lifetime management is something we should also consider. And cost is definitely the biggest issue overall. So our algorithm, just to share, if you have a severe TR, we heart team think we need intervention, then we need TE and TE assessment and hydrate the patient and proper assessment, right heart catheterization, and we also determine the image quality. If it's not quality, it's not good for clipping, then we not proceed. Even anatomically may be suitable. So TR is the first choice. If anatomical not eligible, we do a CT scan. If the CT scan is okay for a replacement, then we go for a replacement. If it's not, then we may consider heterotropic TTVR, and maybe a trick valve is under consideration. It's complex scenario, maybe hybrid combinations, but maybe surgery, because we don't want to just do this very challenging procedure in patients already with a very complex, poor RV to start with. And overcoming suboptimal TV in the imaging, and now we're adopting this 3D eyes protocol, and you can see it's really well delineated of the leaflets. You can switch between, for example, this Philips system, switch between the TE probe and also the eyes probe, and actually make the procedure much faster and more reliable. So in summary, so we know the technology is advancing, but we are not still in an early stage to say who is the winner. But most importantly, you will definitely lose if you did treat late, because when everything, RV failure, patients deconditioning all come into play, no matter how good you perform the procedure, what kind of device you choose, it won't help the patient. So thank you very much for your kind attention.
Thank you. We have clearly have a lot to learn about tricuspid valve therapies. Let's, if we can, go back to Los Angeles, to Raj and your tape case. Hi, Raj. You have the floor.
Can you? Yes. Can you hear us?
Yes, I can hear you. Are you going to narrate as it goes?
So what we will do is, we are here, and Akriti is also here with me. She did the procedure with me, so we can answer any questions. But let's start, okay, to present to you this recorded case. We are recording this for Asia Pacific Valves today because Raj Makkar, who's our imaging expert, has to be leaving the country. But let me go ahead and introduce our team. Okay, so I'm Raj Makkar from Cedars-Sinai, Los Angeles. To my right is Dr. Akriti Gupta, and then we have Syed, who's our interventional fellow. Dr. Raj Makkar, as I mentioned, is actually doing the imaging for us. So I'm going to ask Syed to go ahead and present the case, please.
Sure. So hello, everyone. This is an 89-year-old gentleman with a past medical history of severe symptomatic functional tricuspid regurgitation. He has class 3 and 4 New York Heart Association classification symptoms. His KCC Q score is 44. His past medical history is significant for heart failure with preserved ejection fraction. He was recently admitted with acute heart failure exacerbation. He's also known to have diabetes, permanent AFib on apixaban. He had a history of AV block and has a pacemaker and history of COPD. So here we have some echocardiographic images that show that there is significant severe MR in the RV inflow view, and there's also severe TR, and there's also impingement of the posterior leaflet by the pacemaker lead. Next slide, please. So there's some TE images that are again consistent with severe, very severe TR, and Dr. Raj Makkar will be reviewing them in detail shortly. Next slide, please.
All right. So let's do this. Why don't we have, we are going to ask Dr. Raj Makkar to actually talk a little bit more about the TE findings.
Okay, thank you, and hi, everybody. Delighted to be with you guys to show you this very interesting case of TAVR. So as you can see here, this is the RV inflow view in the deep esophageal. And this is one of the views that we started to learn and master more and more often as we have get into the transcatheter tricuspid therapies. Because the window here for your tricuspid valve is through the right atrium. You're facing the tricuspid valve directly. And you can see a very, very clear view of the tricuspid valve. And you can appreciate here the aortic valve. And this is where they call the RV inflow view with that. And you can see the anterior leaflet here attached to the aorta. And the posterior leaflet is on the other side. And you can appreciate that the jet is coming centrally. And there's a pacemaker lead that is impinging on the posterior leaflet. Once you put an X-plane through that, where you get the opposite, X-plane through that, where you get the almost the 180 or 190 degree, where we have the septal leaflet on the left side of the screen, and then we have what we call during the case the lateral leaflet. This lateral leaflet could be cutting through this part, anterior part, which could be anterior leaflet, or it could be a posterior leaflet. So as you see here in this view, for example, we're cutting through the posterior leaflet on this side, and you can see the impingement of the pacemaker lead on the septal leaflet in this side. If you move a little bit more in the center, you can see the big gap, and this could be the anterior leaflet or the posterior leaflet, and with a big gap in the middle. And then as we move more towards the aorta, we cut through the anterior leaflet and the septal leaflet. So this is going to be our working view, in addition to the transgastric view that we'll show you in a second here. So it's a very, very common that you guys see the transgastric. This is the second important view for imaging the tricuspid valve. And you can see the aortic valve on the bottom here at 5 o'clock. And then this is going to be the septum of the heart. And so this is going to be the septal leaflet, anterior leaflet, and this is going to be the posterior leaflet. And you can see again the position of the lead is embedded all the way in the commissure between the septal and the posterior leaflet with that. And this is going to be one of the things that during the case that we're going to start to be looking for. This is the 3D view of the valve, as you see here. And again, we orient it to be similar to the tricuspid valve with a 5 o'clock view of the aortic valve, so that we're all going to have the same familiar images. We're not going to struggle to identify which part is which. And then we go and trying to size the annulus based on the NPR. NPR has become the must now in the leading field of the interventional echo. And we get a circumference of 133 with a maximum diameter of 49 and 32. And this is all consistent with the measurements of the CT scan that we rely primarily on. TE is just for the confirmation.
Obviously both tricuspid valve repair, TEER, as well as replacement are approved by the FDA in the United States. So Moody, can you tell our audience why we decided to go for replacement here instead of repair?
In this situation here, we looked at the pacemaker lead. We see the pacemaker lead is really impinging on the septal leaflet and creating a tethering of the septal leaflet with a big gap. Makes it grasping in this area and decreasing the TR is going to be very, very tough. The second component that comes into the play are the gaps between the anterior posterior septal leaflet and between the anterior leaflet. And you can see here the gap is very large, and we can measure it by just a quick measurement. It's going to be about 1.1. Anything that is more than 6 millimeters is usually a very hard to grasp and to get a good result.
Terrific. All right, so let's talk to the audience now. So what we've done here is we actually have an 18 French Cook sheath in the right femoral vein. We have this Boston Scientific deflectable catheter, and we have a safari wire through that. Okay, so let's go ahead and see if we can advance. Okay, so let's take this out, please, the dilator from the deflectable sheath. We'll keep the, okay.
So here the goal will be to have the wire anterior, exactly how you did to the lead.
All right, so as you can see that the loop of the safari wire is next to the tip of that pacemaker. And then Moody, are you satisfied with where we are sitting in the RV apex?
Yeah, so right now to confirm the wire placement, which is very, very important to make sure you are in the deepest part, the apex of the right ventricle, and you're not entanglement, we go to the transgastric view, and we're trying to get a good view of the tricuspid valve here with the wire inside. So,
okay, so we are clocking it, we are counterclocking it, and this is going more anterior. I think I need to be more here inside. Okay, so I think it looks...
So you can see the wire here, the loop of it is going all the way in the apex here. So that's a very, very good confirmation, and it's in a good position.
Okay.
That was
Akriti, can you please walk this catheter back, keeping the safari wire in the RV apex?
You can see this is where the wire is.
Are we ready with the valve system? Okay, let's go with the dilators. We are going to go ahead and dilate the track. The biggest dilator is 33 French. The Evoke system is 28 French. Laura, please.
Raj, what was that catheter you used to steer into the apex?
It's called direct. Doing this, you don't want to lose your position in the...
Is it like an Agilis a little? Or?
Yes.
Okay.
Yes, it's like a Gillis, but I think it's 12 French. And in this case, of course, you know, it works very well.
Just need to know all the new brands. You can't keep track.
The Agilis works, but occasionally the safari wire overpowers it.
Okay.
And we've had times when the Agilis catheter sort of almost breaks.
Okay. I want that.
Used to do Oscor.
Yes, there's another catheter called Oscor.
What made you move away from Oscar?
We can't hear you so well, Akriti. You're quiet.
And I was just saying, in the early days, we used to use Oscar. That's another deflectable catheter.
Great. Now we can hear you fine.
Can go up. Volume up. Tricen 2 study. Okay. So this is the system, and essentially what you have is an inline sheath. This is the inline sheath. And the valve is contained in this capsule. Okay, so you're advancing.
So imaging-wise, I'm getting here to do the MPR, which is going to be our working views throughout the case, where we have the aortic valve here, RV inflow. I'm going to call this side here anterior, posterior, and this side septal, lateral. And as we getting the system, and you can see the short axis view here.
Yeah. Okay, so Moody, I want to point out to our audience how we are going forward. So while Akriti is maintaining traction on the wire, I'm deflecting the catheter using what is called a primary knob. Okay. As we go in. Okay. Okay, so I think you are showing us beautiful pictures, Moody. So this is pretty much, there's a little posterior trajectory, but we are pretty much in the middle. Would you agree with that?
Yes, exactly. So here we won't like to be in the middle, but you can see there's a little bit of posterior trajectory here. And between the septum and lateral is a very, very nice. And you can see the double line here. This is where the anchors is going to be coming out. So that's why I would like the anchors to be coming out just under the leaflet. So it's important to know how deep or high you are from the tricuspid annulus.
Okay, terrific. So what we are doing is we've put this delivery system in this cradle. We are going to bring the inline sheath back, and this will sit here in this groove. Okay, now let's tell the audience about this valve and this delivery system. So this valve is a self-expanding valve. It's double-framed. It has 9 anchors, and it is contained in the capsule, which is at the end of this delivery system. Now, essentially, there are a number of knobs, as you can see. So the first 2 knobs are the knobs that actually help in releasing the valve. And all of these knobs, so these 2 knobs, help in terms of positioning the catheter as well as in terms of controlling the trajectory. This is a knob that allows you to go deeper into the ventricle, and when you want to lose the depth, okay, if you have given depth, you can just turn it in the opposite direction. Now, there are other things. So, for example, what this knob is a primary knob will do is it'll actually help you go anterior or posterior in terms of trajectory. So as you can see, that we were actually looking a little posterior. So we can go ahead and give more primary. Can you show us the position so that we can make the illustration there?
Yeah, so I'll show it to you here.
So we can go anterior or posterior with this knob. We can go, okay, so there it is, right? If we wanted to go anterior in position, we can also move the whole thing forward, which can be done this way. So this is what helps you to go anterior or posterior in position. This knob helps you to change the trajectory in the anterior posterior direction. Now this knob allows you to go more away from septum. So let's say if we were to go ahead and use this knob, we will move away from the septum. But we can also move away from the septum by rotating this. So if you go counterclockwise, as you can see, we are moving away from septum. If you go clockwise, we are moving towards the septum. All right, so these things will allow you to be central, and they will allow you to be coaxial when you are trying to deliver the valve, essentially by capturing the leaflets. Okay, so that is how the anchoring will occur. So let's go ahead now and create a capsule gap. So the goal is to see, where is the valve? Okay, are we high? Are we low? Okay, so we have created this gap. It's easier to see the gap between the nose cone and the catheter. So can you point out that for us, please?
Yeah, it's here. So and this time, this is going to be where the blue line is going to be happening, where the anchors is going to be coming out. Yeah.
So Moody, do you agree that we need to be a little bit deeper?
Exactly. So
the least amount of depth that you need is that you need to be below during the systolic coaptation. So we can let go a little bit of the primary. So I think one of the more important things that we forgot to do is a timeout. So before, we've come back a little bit here, but you can bail at this point, okay? So let's say if you found out that you don't have enough reserve in terms of using different maneuvers or knobs, you can say, we are not going to do this procedure, and you can come out. Once you start to release the anchors here, then it is not possible to bail, okay? So we have used almost maximum primary, okay, a little bit is left. We have used no secondary. We have used, what is the depth? Okay, so we've used about 0.5 depth. So we have reserve there, and then we are about 2:30, between 2 and 3 o'clock here. So which is, whether you can go septal or you can go lateral, and that's acceptable. Okay, so we have some reserve.
My concern will be that we are very, very posterior at this point and interacting with the pacemaker lead.
Yeah,
so
okay,
especially if we can move it a little bit more.
So we can move this.
Yeah.
Right there.
Exactly. So that looks much.
All right. So we just went up a few clicks. So we are going to go ahead and see, as we release this, it goes a little bit anterior anyways. You know what I'm saying?
You can start to see the anchors are starting to peak from here.
Yeah.
As you notice this.
Okay, and then what we will do is we'll gain some depth by giving a little bit of depth here. So one of the things is that as you are releasing the valve, it foreshortens. You want to make sure that you don't come above the leaflets. So that's an important aspect. So a lot of times, as you're expanding...
We are lateral here. We need to go a little bit more septal.
Yes, okay.
Raj,
So
how much longer do you have? I just want to make sure we accommodate.
I think we have sufficient depth. Would you agree?
Yeah, sufficient, but I see there's a little bit of posterior trajectory here.
We have 8 minutes.
And,
is it possible, or should I just...
Thanks.
Okay.
No, it's very interesting. We don't want to miss.
Okay. What do you think?
Yeah, I think it's good. We're right now at 90 degrees, and you can start to see that there is the anchor, and there are 9 of them are here coming out. And what we'd like to do is something called the spin right now, where we spin through each anchor to make sure we're capturing the leaflet, because at this point the width of the wheel or the valve at this point is about 30 millimeters. And we want to make sure we're positioned. As we get bigger, it becomes even more and more hard. So one of the things that's unique for this procedure is something called the spin, where we identify anchor by anchor. So we start from the 6 o'clock anchor, which is going to be corresponding or be seen on the blue box at the right side. And this is where we're going to go and start to see is the leaflet captured. And you can see the leaflet is above and inside here. So it's going to be one of 3 things. Either capture the leaflet, or pinning the leaflet means that the leaflet is getting outside the device, or it could be capture ready, meaning the leaflet is going in and out with capture ready. So as you see here, that we captured the 6 o'clock leaflet nicely inside, you can see the anchor there. Then we move on to the 7 o'clock anchor, and you can see again, on the green box on the right side, you can see the leaflet is sitting above the anchor very nicely here. And then we're going to go and move. Usually you go about the 8 o'clock is the shadow from the device, and this is something that is very, very common to see, so we're not sometimes able to see, but we can appreciate that there is an anchor here, and the leaflets are nice and above it. Now moving to the 9 o'clock anchor, you can see it's nice and captured here, again, observing that. Next view will be the 10 o'clock anchor. Again, we go spanning through it. It's nice and captured here. So then we're gonna go through to the 12 o'clock anchor, and you can see, appreciate the leaflet is nice up inside. And this is where the leaflet was tethering, and this is where the pacemaker lead is. So we wanted to make sure we're capturing the leaflet in this part. Then we're gonna go to the 1 o'clock anchor, and you can see it very nicely. Actually, you can see the leads here, and you can see the anchors, and you can see that the leaflet was just behind it, meaning they're in a good position. Next is gonna be the 3 o'clock anchor, and again, it's nice and captured in this view here. And then I'm gonna go, next one here is gonna be the 4 o'clock anchor, nice and captured. And then finally, we're gonna go back to the home view, which is the 6 o'clock. And then we're gonna go back, and then, so we have confirmation that we have all the leaflets, we have a good trajectory, and now we're gonna be ready to proceed to the next step.
Okay, terrific. Thanks, Modi. So we have everything captured, or nothing is pinned. So we are using the white knob to do what is called ventricular expansion. So we, of course, have the anchors that are at 90 degrees, and they are going to flip now as we continue to actually release the valve. And as you see that we did come up, so we just are going to go ahead and add a little bit of depth. Okay. All right. Now, as we continue, now the size of the valve will actually increase. Okay. What about our Edwards team? What do you think? Are you guys happy? You're happy? Okay, very good. So we will now pull the nose cone, which also helps us, go up a little bit.
After capturing all the leaflets, the next step that needs to be paying attention to is the height or the depth of the leaflet.
Yeah. So we at no point we would like to come up above the annulus. Okay. All right, Akriti, if you can pin.
You can see here in the AP view, and you can see in the SL view here, that is just at the level of the annulus in a very, very nice way, and we still have a full capture of the leaflet.
Great. So we've completed what is called ventricular expansion. Yeah? And then Akriti was very much worried about the lead, and I think, I think so far we may be okay. Yeah? All right. So now we will go and switch to what is called the atrial expansion, which is using this blue knob. We will expand the rest of the valve, and which will ultimately lead to the release of the valve. Okay? So we will now start. Shall we lose a little bit of depth?
I think we're very good here on the AP and the SL.
You're right. It's actually not so bad. I think it is.
I don't see any
not bad at
between
all.
them. I can go and move it to the other side of the shadow here, and still looks reasonably.
Okay, so we continue to expand, as you can see. So this is just about to release. Okay.
Here, as you see, once it starts to get bigger and bigger, the images start to get worse and worse and degradation. But at this point, we confirmed from all before that we have all the images.
As you saw, we pulled the nose cone back into the valve.
The pressures are down a little bit. We have a little bit of. I think we need to release it.
We need to release the valve. Okay. It's unusual for the pressure to come down. I think we had a little bit of arrhythmia. But as you saw that the valve is now released.
Raj, are we almost done? They are waiting for us in another live case.
And the
yes.
So the valve looks. So this is just 1 minute.
Yes, no, I want to see as much as we can.
So Akriti just pull the nose cone back. So it's above the valve, so we are in good place. And then we will also go ahead and release or go back, revert all the knobs to where they need to be. So we start from here. We actually lose all the depth. Removing the system, and then let's show the final picture.
TR completely.
All right, so we remove the safari wire, and we like to remove it through a multi-purpose catheter, so we don't snag onto anything. So that's out. Our rhythm is stable, blood pressure is stable, the valve is not rocking, it is just nicely stable. And there is no tricuspid regurg. No PV leak either, right?
Yeah, it's only around the pacemaker lead. That's the only thing.
Okay.
Here, so.
Just
but
a
as
little
you can
bit.
see, this the valve is working and
I
functioning.
think
The
that's,
leaflets are moving.
yeah, so that's it. You
No,
saw,
that's,
you saw-
Raj, I wish we could have more time because, again, there's so much to learn here, and most of us have not done a evoke yet. And so we really appreciate your taking the time and leading us through that. And you made it look easy. I don't think it's quite that easy, at least based on the cases I've observed so far. So well done. And we really want to thank you and Akriti and the whole team at Cedars for spending some of your evening with us and really teaching us so much. So thank you very much, Raj.
Okay. Okay, it's a pleasure. Bye-bye.
All right, I'm sorry we went over, but we will wrap up this session and turn over to the next crew. Thank you very much, everybody.